Thank you, Madam Speaker and honorable members. This question reached me this morning while I was actively participating in the Public Investments Committee. So I have done my response, but I would also seek time so that we can submit other comprehensive documents. Honorable Speaker and honorable members, for the 3 financial years requested by the Member of Parliament from Ecology by honorable members, indeed it's my first time to appear before the full House to directly interact with the honorable members, as my previous engagements have been through the committees. I therefore submit as follows on the question that has been raised by the Honorable Mishimboko. Honorable Speaker and honorable members, as a country, we suffer from periodic cholera outbreaks every 5 to 7 years since the first cases was reported in 1971. The current cholera outbreak has been ongoing since October 2022, and to date, we have reported 12,000 cases and 197 deaths. Honorable members, to mitigate this, the Ministry of Health, in conjunction with other sectors of government, including the Ministry of Water, Sanitation and Irrigation, the Ministry of Environment, Ministry of Interior and National Government Coordination, development partners, religious leaders, the media and the county governments, we developed 2022 to 2030 National Multi-Sectoral Cholera Elimination Plan, which my colleague at Ministry of Water and myself have endorsed, and it is due for launch this month. The plan aims to implement several promotive, preventive, and response interventions before and during outbreaks. The main interventions include engaging communities to use latrines, practice hand washing with soap and water, use treated or boiled water for drinking, and keep their environments clean. The government is also expanding safe water and sanitation infrastructure across the country. In addition to these traditional cholera prevention and control measures, the country conducted its first oral cholera vaccination campaign in February 2023 in the highest risk sub-counties in line with our multi-sectoral cholera elimination plan. The goal of the National Multi-Sectoral Plan targets to reduce local transmission of cholera cases to 0 by 2030 and reduce cholera deaths to 0 by 2030. We have just concluded the second phase of the campaigns, which was done in August 2023, this past weekend, in 8 sub-counties of Embakasi Central, Kamkunji in Nairobi, Kajiado East in Kajiado, Wajir North in Wajir, Suba South in Homa Bay, Moyale in Marsabit, Mandera East in Mandera. We also targeted institutions in Machakos and new arrival refugees in the refugee camps within Garissa. The August 2023 campaign targets to reach 1.7 million people. The February campaign involved 9 sub-counties in 4 counties, Embakasi East and Mathare in Nairobi, Wajir East and Wajir South in Wajir, Garissa Town, Dadaab, Fafi, Lajera, including the refugee camps, and Bura in Tana River County. We targeted to reach 2.2 million people, and we were able to vaccinate 99.2% of them. As a result of the campaign, we saw a drastic reduction in cholera cases in the affected counties and also nationally, in a table that I have attached to my presentation. Speaker and honorable members, the contributions of International Coordinating Group, including vaccine doses and conditions. The International Coordinating is Medicines Sans Frontiers, which is an independent field-based NGO that provides healthcare to vulnerable populations in emergency settings. The third agency is the United Nations Children Funds, UNICEF, which conducts vaccine procurement and shipment, management, surveillance, preparedness, and response to disease outbreaks. WHO also functions as a secretariat for the ICG. Honorable Speaker and honorable members, vaccine manufacturers, vaccine equipment providers, and financial donor institutions are also engaged in the ICG operations. The core mandate of ICG is to make available and ensure equitable access to licensed vaccines for cholera, meningitis, yellow fever, and Ebola virus disease during outbreaks. The ICG manages the global emergency vaccine stockpiles and, working with partners, donors, and manufacturers, determines the size and composition with the goal of ensuring that adequate stocks of emergency supplies are accessible for emergency response. Honorable Speaker and honorable members, vaccine security stocks can be accessed by any country facing any epidemic anywhere in the world, as long as the country request fulfills the ICG's criteria for release of vaccine stocks. As a first step, a country must complete and submit a request secretariat the standard application forms. The annexes and other relevant documents should be submitted alongside the application. Countries are encouraged to submit the request to the ICG Secretariat within 7 days after confirmation of an outbreak. The ICG Secretariat at WHO then circulates the request for agencies within a day after reception and review country submission. Additional information can be requested from the country if need be. Honorable Speaker and honorable members, requests are evaluated considering the epidemiological situation, vaccine strategy, vaccine availability in the stockpile, pre-existing stocks in the country, and operational aspects at the epidemic response. Gavi, the Vaccine Alliance, finances the ICG stockpiles of cholera, Ebola, meningitis, yellow fever vaccines, and Gavi-eligible countries can receive the vaccine free of cost. Non-Gavi supported countries are responsible for reimbursing the cost of the vaccines and its transport for finding a source for the operational costs of the campaign. Once the request for vaccine supplies has been approved by ICG members, a process is put in place to ship the vaccines and supplies. Prior to shipment, the recipient country must demonstrate that there is sufficient cold chain capacity to receive and store the vaccines and supplies. Additionally, customs and regulatory approvals must be granted and provided to UNICEF. Honorable Speaker, as a country, we have categorized all counties according to their cholera risk status as part of our national plan. For the February campaign, we received 842,952 doses of the vaccine, which was sent to Dadaab and Fafi sub-counties and the refugee camps. And we also received 1,370,991 doses of the Uvocol vaccine, which we sent to Bura, Lagdera, and Garissa, Wajir East, South, Embakasi East, and Madare. The Gavi Alliance supported the vaccine and operational costs of the campaign. WHO is responsible for funds administration in country. During the current round, we targeted 13 counties based on their confirmation of outbreaks, but only 5 high-risk counties, namely Nairobi, Kajiado, Marsabit, Homa Bay, Wajir, were approved, including institutions in Machakos and new arrival refugees in Garissa. Mandera East was also considered in the Mandera Triangle application. That had included all the counties bordering Somalia and Ethiopia. A total of 1,710,900 vaccine doses were approved for the August 2023 campaign. From the foregoing, only small fractions of our requests are approved for outbreak response. This is because of the limited global stockpiles. There are many ongoing cholera outbreaks in many parts of the world, including our neighboring African countries. The ministry is, however, working with the ICG, the Global Task Force on Cholera, and Gavi to finalize the multi-year preventive oral cholera vaccine plan to ensure we protect the high-risk counties. Speaker and honorable members, I would like to emphasize that the oral cholera vaccine is a complementary intervention that must be implemented alongside the basic water, sanitation, and hygiene measures. On the third part of the question, honorable Speaker and honorable members, the strategies that the ministry, in collaboration with county governments, have put in place to ensure effective distribution and administration of the vaccine. Honorable Speaker and honorable members, the ministry, in conjunction with participating counties, has established incident management structures at both levels that comprise teams responsible for coordination, planning and logistics, management and operations. To ensure effective distribution of vaccines, national and county teams have been trained on all aspects of the campaign which not only include vaccine administration, but also surveillance, case management, prevention, risk communication, and community engagement. Granular microplanning at county level has ensured that all households and other areas of community congregation have been mapped and are being visited by vaccination teams. Our primary vaccination strategy is through house-to-house visits. However, we are also vaccinating in health facilities and temporary fixed posts such as markets and schools in the participating counties. We also have teams specifically trained to reach hard-to-reach areas and transit areas in the counties. To support these efforts, transportation and facilitative field allowances have been supported by the Gavi Alliance through the ICG. The Ministry and the County Departments of Health have trained and deployed supervisors at all levels. We have also deployed innovative ICT supervision tools to monitor the campaign. We are also reviewing daily campaign performance through daily review meetings at both national and county levels. The number of personnel involved and resource allocated to the ongoing cholera vaccine drive, Honorable Speaker and Honorable Members, a total of 14,812 personnel are involved in the campaign directly. This number includes community health promoters, healthcare workers acting as vaccinators, field team supervisors, sub-county supervisors, county supervisors, national supervisors, and partners supporting the field teams. The total operational costs for the campaign is 129,422,534 Kenya shillings. I submit, Chair and Honorable Members.
Thank you, CS. We will allow the questioner the first chance to ask a follow-up question, then we'll have one more, as has been guided by the House. Honorable Mishi.
Thank you, Madam Speaker. Madam Speaker, I just want to appreciate the Cabinet Secretary for a detailed response on my question, but I just want to put a supplementary question on what he has just answered. As we see that the El Nino is just around the corner, I just want to understand whether there are some areas of collaboration which have started engaging the county government to ensure that the El Nino is not going to affect most of the part of this country. I'm thinking on the area of poor drainage facility, the issue of poor sanitation. So which mechanism have you put or other measures to ensure that when El Nino is here with us, then there are some measures which are there to protect us? The other issue is that because now you are through with the pilot program on the cholera vaccination, when are you going to roll out the full vaccination to all counties? Because now, because of El Nino, it's like all the counties are going to be affected with waterborne diseases where cholera is among them. Honorable Speaker, I also want to understand whether there is a component of training to the officers who are going to be doing reach out programs in terms of the oral cholera vaccination. Because right now in Mombasa, there are still some officers who are complaining that they were not paid, they were not trained, and yet they were involved in this process. I thank you, Madam Speaker.
Honorable CS, note the follow-up questions, and you'll do one response. Member for Yatta, if you're willing to ask a follow-up question, kindly indicate in the intervention.
Thank you, Madam Speaker, and thank you to the CS. I think my question ties to what Honorable Misho has already asked, but on medical supplies, how many medical supplies or how much are you budgeting for medical supplies in most of the constituencies? Thank you.
CS, please take and answer those follow-up questions.
Thank you, Speaker and Honorable Members. On the preparedness for El Nino, Speaker and Honorable Members, we have a multi-agency, multi-sectoral committee being chaired by the Deputy President, which we did our first meeting last week on preparedness. And equally at the ministry level, we have a committee that is working on preparedness. We have submitted our budget to the joint committee of the multi-agency that is being discussed this evening. Chair, Speaker, and honorable members, regarding the payment to the staff who worked on the cholera vaccine, I have confirmed that at the ministry level, we have done all payments. But also want to say that this exercise was being done in collaboration with the county governments. So we will need to verify if all county governments have been able to pay their people who participated in the vaccine campaign. Lastly, Madam Speaker and honorable members, on the issue of supplies, we do our annual budgets for health commodities and supplies, and so far we have been able to put to tender for this year a total of supplies worth 5 billion shillings, and that is to cater for all the facilities. But Chair and honorable members, I would like to say that it is the responsibility of the county governments to make their orders to our Kenya Medical Supplies Agency for the supplies to be able to reach them. So we shall be working collaboratively to ensure that then the facilities are well equipped with the commodities that they require for healthcare. I submit.
Thank you, Honorable CS. We'll now move to the next question. The member for Ikolomani, Honorable Bernard Shinali, had written to the Speaker and requested that Honorable Titus Hamala ask the question on his behalf.
Thank you, Madam Speaker. I'm standing in for Honorable Shinali, and it's question 011 of 2023, question Roman 1. Could the Cabinet Secretary provide details on the amount of money that the National Hospital Insurance Fund, NHIF, has disbursed per county with respect to financial year 2020 to 2021, 2021 to 2022, and financial year 2022 to 2023 towards the implementation of the Linda Mama Boresha Jamii program and enrollment of the poor households to the NHIF scheme. Question Roman 2, explain the measures that the ministry has put in place to ensure timely disbursement of funds to the NHIF in order to guarantee seamless access to service under the fund. Thank you, Madam Speaker.
Waziri.
Thank you, Madam Speaker and honorable members. This question reached me this morning while I was actively participating in the Public Investments Committee. So I have done my response, but I would also seek time so that we can submit other comprehensive documents. Honorable Speaker and honorable members, for the 3 financial years requested by the Member of Parliament from Ikolomani, the NHIF disbursed a total of 14,550,650,327 Kenya shillings, broken down as follows. 2020-2021, Kenya shillings, 4,950,996,788. The year 2021-2022, 4,659,611,252. 2022-2023, 4,940,042,287 shillings. More so, Honorable Speaker and honorable members, for the year 2022-2023, 253,400 were supported under the health subsidy programs of orphans and vulnerable children. The same year, 587,900 were supported under the health subsidy programs for older persons and persons with severe disability. And lastly, of the same year, 978,484 persons were supported under the UHC program. On the second bit of the question, Honorable Speaker and honorable members, since April 2023, my ministry has endeavored to reach out to all government entities that owe money to the fund. Of the 26 billion owed to the fund, we have received 13 billion from other government agencies. That is at the close of 2022-2023. Honorable Speaker and honorable members, it is a continuous exercise to keep speaking to the other government agencies, which I do, and I will not tire to remind all that owe money to the fund to meet their obligations for effective and efficient service delivery to all Kenyans that depend on us. Honorable Speaker and honorable members, Per county tabulation, I have it, but it is such a huge document, about 20 pages. If I went through column by column, Honorable Speaker, I would take a lot of time, but I stand guided. I have it with me. I submit.
Honorable Titus.
Thank you, Madam Speaker. Just a follow-up question to the CS. Honorable CS, are you aware that we still have a lot of challenges when it comes to NHIF, whereby you find accredited hospitals and medical centers, but when patients show up with NHIF cards, they're still turned away? And just in addition to that, to this question that I'm asking you, I personally went to a clinic at Gateway Mall, Mombasa Road, and when I showed up with my card, I was told that it can only cater for consultation fees and nothing else. I don't know if you are aware. Thank you.
Mheshimiwa Zamzam.
Asante sana Mheshimiwa Spika, na mimi swali langu linaenda kwa Waziri wa Afya. Sote tunajua kuwa NHIF inasemekana kuwa itarudi upande ule mwingine katika vitengo vitatu. Mheshimiwa Waziri, mimi nataka kujua wale wafanyikazi ambao walikuwa wakifanya katika idara ya NHIF, mumewapangia kitu gani? Maanake tunasikia wengine watambua ende nyumbani. Hawa ni wafanyikazi na Kenya na wakati mgumu sana. Kwa hiyo naomba unijibu kuwa wale wafanyikazi wa NHIF mmewapangia kufanya vipi? Asante sana.
Honorable CS, I want to note to you that the bill is still in Parliament. On the question of Mheshimiwa Zamzam, respond to the honorable question from Honorable Titus. This one, the bill is not even assented by the President, so let us avoid preempting bills that are still before the House or the Senate. So answer to Honorable Titus, and I think I would direct that the document that is one of your responses be submitted to the questioner so that he can be able to follow up on the question.
Thank you, Honorable Speaker and Honorable Members. I appreciate the question, and it actually highlights the challenges, the many challenges that we have at NHIF. Honorable Member, you have listed about patients being turned away, that they are not able to use their card, and equally you have highlighted that at times when you appear, you are told that it can only cover the consultation fees. Honorable Speaker and Honorable Members, we have a myriad of challenges, and that is why we are working on reforms of being able to reform NHIF, so that we are able to work on this. And Speaker and Honorable Members, we have now defined essential benefits package, where all Kenyans will be able to access services without a limit and without exclusions. And therefore, Honorable Speaker and Honorable Members, I would like to seek indulgence of members that you allow us to go through the reforms that we have put at NHIF, so that all this myriad of challenges that we experience, we can be able to put them behind us. I submit, Speaker and members.
Bomboko, what is out of order?
Honorable Speaker, with respect and thanks, I see a danger of the CS telling the House that people will not receive medical care until when we do the reforms. I totally agree with you that in terms of the reforms, the bills are here and it's still property of the House. But meanwhile, as a follow-up of what Mheshimiwa Amala was saying, does it mean that, Honorable Speaker, does it mean then that no NHIF services will be provided until when we transit? That's a danger given that people are outside, they are sick.
Thank you, Honorable Member. Honorable CS, can you clarify?
Thank you, Honorable Speaker and Honorable Member. Services at NHIF are continuing to be offered, and we are continuing to work. We have actually just finalized a governance issue where we now have a CEO who we shall be announcing in the next few days. We have directors who are now going to ensure that management of NHIF as it is, even as we plan for transition, is able to operate optimally. Honorable Speaker and Honorable Members, we are also leveraging on technology. So we are introducing technology so that the current NHIF in its form can still leverage on technology and provide services. And we have a whole 1 year in terms of planning and providing services to Kenyans. So we'll continue to take feedback and to tighten where we receive feedback that we have loose ends, we'll need to tighten. And specifically on these issues, Honorable Speaker and Honorable Members, I will do a follow-up with the NHIF. I submit, Speaker and members.
We'll go to the next question, the member for Masinga, Honorable Joshua Mwalio.
Thank you very much, Madam Speaker. I rise to ask the Cabinet Secretary for Health. Could the Cabinet Secretary explain the reasons for failure by the Kenya National Hospital, KNH, superannuation scheme, DB scheme, to settle pension benefits owed to retirees, its non-compliance with the updated and applicable calculations of such a pension benefits, and state the genesis of the miscalculations. Roman 2, provide details on the status of implementation of the decision of the Retirement Benefits Authority of 18th April 2019 on a pension dispute and a subsequent ruling by the Retirement Benefits Authority Appeals Tribunal, RBAT, dated 21st April 2021. Roman 3, provide a definite date when the affected retirees will be paid their dues, which have been pending for years and continue to attract interest to date.
Honorable CS.
Thank you, Honorable Speaker and honorable members. On that question, I will respond to the part 1 of the question, and then on part 2 and part 3, I will give an explanation and a request to the House. Honorable Speaker and honorable members, Kenyatta National Hospital Pension Scheme, that is the defined benefit, has endeavored to pay pensioners promptly and without default. And that is to clarify that on a monthly basis, the retirees get their pension. This scheme was closed to new entrant via a government directive treasury circular of number 18, 2010, dated 24th November 2010. There have been concerns, however, on how the benefits have been calculated, especially after the closure of the defined benefit scheme to new entrants. As stipulated by the Retirement Benefits Authority, schemes are guided by the trust deeds and rules, and as such, the Kenyatta National Hospital defined benefit scheme is guided by the trust deeds and rules. At the point of closure, the trustees amended the trust deeds and rules to allow the closure with effect from 30th June to 2011 with the following amendments. Pensionable emoluments were to be increased at a fixed 5% per annum with effect from 30th June 2011, and that was considered as the closing date. Pensionable service for all members would be frozen at the closing date, and future service would be accrued in the new definition contribution scheme. This amendment was rejected by the Retirement Benefits Authority, indicating it did not conform with the existing laws in the following ways. Members aged 45 years or above as at the closing date were to be given an option of remaining in the scheme and continue to earn benefits in respect of pensionable service after the closing date. The evaluation rate of 5% per annum did not meet the minimum threshold of 7% as set out in clause 321 in the Prudential Guideline for Scheme Conversion. Guided by Retirement Benefits Authority, the trustees amended the TDR, and the closure terms of the scheme were then revised to ensure compliance, and members above 45 years were given the option to remain in the scheme. The change of the evaluation rate from 5% to 7% led to the first recomputation of benefits in 2017 for all members who had left, and benefits were calculated in line with the original closure terms, and shortfalls were paid with interest from the original date of calculation. In 2017, trustees received complaints from pensioners that the salary applied in the recomputation was not the salary at the point of exit, but rather the salary at the closure date of 30th June 2011, which grew at 7%. The recomputation of the benefit was done and the additional benefits paid. In 2019, the retirees petitioned the Retirement Benefits Authority, questioning the trustees' use of pensionable salary capped as at June 2011 and not salary preceding retirement date. These complaints have developed and led to a decision by the Retirement Benefits Authority dated 18th April 2019 and the tribunal case. Honorable Speaker and honorable members, I have learned this morning that we have a new direction from the Retirement Benefits Authority. So I would like to seek the indulgence of the Speaker and honorable members that you allow me to go and look at the new regulations that have been issued and provide a substantive response up to the effective dates, that is to part 2 and part 3 of the question in a future date at a time when I'm allowed to do so. I thank you, Honorable Speaker and members.
Honorable Mwalio, I will give you the first go, also noting the explanation by the CS on part 2 and 3.
Yeah, in the response, it was, you had indicated that the settlement will be done on 30th November. Now, are you saying that the directive that you have now gotten is different from what you have written here? And can you, if that stays, if 30th stays to be so, can you commit to this House that 30th will be the final day for them to be paid? Question number 2, the advice of this scheme is regulated by RBA. Why can't the scheme heed to the advice of the scheme and settle these debts once and for all? I rest my case.
We'll have one more question from the member for Tetu.
Thank you, Madam Speaker. I would like to ask the Cabinet Secretary to clarify on the many organizations that have been set up by acts of parliament, but that remain unoperationalized within her ministry. And specifically, I would like her to tell us the status of the Mental Health Board, given that mental health is a serious and emerging issue in this country. And I know there is also the Psychiatrist and Psychologist Board and a few others that have been not operationalized. And that is, in a way, affecting service delivery and affecting how we organize our professionals in this country to effectively offer services. Thank you.
Thank you, Honorable Member. Though that is not related on question 108. Honorable CS, respond.
Thank you, Honorable Speaker and honorable members. As I had requested earlier, it's true I had a written submission and it had a date of 30th November. However, based on the new advice that we have received from Retirement Benefits Authority, I would like to seek for more time, and I can only advise as to when we can be able to substantially close that after I have read through the advice. However, Honorable Speaker and honorable members, I would like to say that since this matter came up, we have had advisories from the Retirement Benefits Authority 3 times, in 2019, in 2021, 2022, and the one that has just come, that is 2023. So I would request for your indulgence that you allow me to look at the new advisory that has come and see how best then we can be able to take care of the retirees. However, Madam Speaker and honorable members, I would like to clarify that on a monthly basis, retirees receive their monies. So it is a continuation, it's an ongoing exercise. It's not like they have been locked somewhere and waiting for this. They keep receiving it on a month basis. Madam Speaker and honorable members, I would also like to say that the same RBA also has given a directive that it is important to note, even as retirees continue to petition for extra benefits, The scheme currently has an actual deficit of 7.5 billion, and the funding level is at 50.1%. Further recalculation of the benefits is likely to bring this funding to below 50%. RBA itself has advised that whenever the fund is below 50%, the trustees will be expected to process benefits to the extent of the funding level with a requirement of the sponsor to cover the balance. The National Treasury has been supporting the scheme, Madam Speaker and honorable members, annually with 100 million. However, this still does not meet, and we have so far put in a request for 300 million for the National Treasury to support. So I'll wait and be able to advise the House at a future date once we have harmonized with the new advisory that we have received. Madam Speaker and honorable members, on the issue of mental health, I would seek indulgence that I respond to it because there is a question touching on mental health. So I'll be able to respond to it. I submit.
That is well noted and agreeable because I also note it is not part of this question. The next question will be by the MP for Kiambu, Honorable Mashua Waithaka.
Thank you, Honorable Speaker. Madam Speaker, I would like to ask the Cabinet Secretary for Health the following question. 1, explain why anti-leprosy drugs are not readily available in public hospitals, forcing patients to source for the drugs outside the said hospitals at exorbitant prices. Number 2, state the measures the ministry has put in place to ensure that the drugs are accessible and affordable. Number 3, indicate what the ministry is doing to reduce the existing stigmatization, enhance public support for persons suffering from leprosy. Thank you, Honorable Speaker.
Is it leprosy or epilepsy?
Epilepsy, sorry. Epilepsy.
Honorable CS.
Honorable Speaker and honorable members, epilepsy is one of the non-communicable diseases which is a top priority for the Ministry of Health. Objective 2 of the Kenya Health Policy of 2014-2030 has prioritized interventions to halt and reverse the rising burden of NCDs. Management of epilepsy is multimodal, including use of medicines, those are anticonvulsants, surgery to remove the part of the brain that is responsible for the seizures, and placing a small electrical device inside the body that can help control the seizures. Drugs for epilepsy management are offered at level 4 and above health facilities according to the Kenya Essential Medicine List. This is because such medicines need to be prescribed by specialists, namely psychiatrists, physicians, neurologists, or senior medical officers who are limited in terms of numbers in the public health facilities. As more specialists are trained and eventually deployed by the county governments, access to anti-epileptic drugs will improve. In line with our task-sharing policy, we have embarked on training of medical officers and clinical officers to manage persons living with epilepsy. This will ensure that patients have access to anti-epileptic medicines, as the facilities will have trained healthcare workers to prescribe and monitor the use of these medications. Honorable Speaker and honorable members, on the second part of the question, my ministry is working with the pharmaceutical sector and other stakeholders on pricing guidelines for health products and technology to address the uncontrolled markup on pharmaceutical products that is a major driver of increasing costs of medicine along the supply chain. Additionally, we are working on strategies for pooled procurement targeting expensive medicines that may not be accessible to a critical segment of the population. Speaker and honorable members, the long term and the solution to this is to promote local manufacturing of health products and technologies and prioritize preferential procurement of locally manufactured medicines and medical commodities. To increase access to anti-epileptic medicine, my ministry has been holding consultations with county governments on the need to enhance availability of NCD medicines, including anti-epileptic drugs. Improving access to anti-epileptic medicines will improve the quality of life of patients suffering from epilepsy, leading to better life and productivity. On the third part of the question, Madam Speaker and honorable members, stigma against epilepsy is real and is due mainly to lack of information about the disease by the general public. Epilepsy is a priority non-communicable disease for my ministry as captured in our strategy plan for 2022-2026. We have undertaken the following interventions towards epilepsy management and support. We have developed epilepsy management guidelines that will guide healthcare workers on the prevention, control, and management of epilepsy. These guidelines are important in ensuring uniform standard quality care is offered along the continuum of care. The guidelines also include aspects of patient education and self-care that will enable patients to manage their condition better at home. We have also included epilepsy in the training manual for community health promoters. In this module, the CHPs are trained on early detection and referral of patients suspected to have epilepsy to health facilities. The CHPs are additionally trained on how to educate and sensitize the public on epilepsy, hence reducing stigma about this disease. In order to raise the profile of the disease, the Ministry of Health has been encouraging counties to commemorate World Epilepsy Day, that is the second Monday of February, to raise awareness among the public and reduce stigma. Indeed, this year, several counties commemorated the World Epilepsy Day. Sensitization on epilepsy through strategic partnerships with patient groups, media, academia, county governments, and non-governmental organizations, e.g. the Kenya Association of Welfare for People with Epilepsy. Madam Speaker and honorable members, epilepsy prevention and control has already been integrated into the Kenya health policy as one of the priority areas. Further, the ministry has developed a national strategy for prevention and control of all NCDs, including epilepsy. These activities include health system strengthening, advocacy, research, surveillance, partnership, and advocacy specifically for epilepsy. There is a designated focal person to handle matters related to epilepsy at the Division of Non-Communicable Diseases at the ministry. We do, however, request for the increased financial support to enhance epilepsy prevention and control now that I'm in this honorable house.
Hold on, CS. Honorable Member for Kwanza, what is out of order?
There's a bit of disruption at the back, and this is a very serious presentation. Would you please make them to talk silently, please, because they're actually distracting us.
The Kamukunji, led by the member for Kabete, please don't distract honorable member for Kwanza. He wants to hear. CS, please continue. Keep your consultations a bit low.
Thank you, Madam Speaker and honorable members. I was actually finalizing on that, and I was putting a request to this honorable house. You are the house that passes our budgets. I would really like to request that we have done allocations for NCDs and request that the honorable members consider it favorably when the next budgeting session comes into place. I thank you, Madam Speaker and honorable members.
Thank you. I'll give the first chance to member for Kiambu, then I will give Honorable Gikaria.
Thank you, Honorable Madam Speaker. Madam CS, you have said that these drugs are available, and I have a concern from one of my constituencies from Tinganga, namely Elizabeth Njeri Etuku, who has visited Kenyatta National Hospital twice, once in July, and she has not been able to access this medicine. So I would urge you to make sure that we have these drugs, because it's becoming very frustrated for our people to access these drugs, and most of them are from very humble backgrounds. Data from the Ministry of Health indicates that Kenya is around 3.4 million people living with epilepsy. with about 3 million adults and 470,000 children aged between the ages of 0 to 17 years.
Honorable Mashua, ask a follow-up question.
Yes,
Not
so-
debate it.
Yes, your Madam Speaker. So I would urge the CS for Health to please, if you can, you give us timelines when you shall have enough drugs to alleviate these problems. Thank you, Madam Speaker.
Thank you. As we get Honorable Gikaria, Honorable CS, ensure you give a correct, timely, and updated information in your responses. Honorable Gikaria.
Thank you, Honorable Speaker. Just a follow-up on what my colleague from Member of Parliament for Kwanza. It is important also maybe, Madam Speaker, to give us a direction as to, when the responses are coming from the CSS, and this is a very important session, is that they are very fast sometimes, as to whether we could be having these things in writing so that we could also be reading, as we are not very good, I'm not a very fast learner, so if I had something, I'm just asking, if that the response were here with us that we could also be following, that would really assist us in making a very meaningful debate and follow-up questions when we want. But all the same, Honorable Speaker, my concern is that can the Cabinet Secretary confirm to us as to when she says that as they are addressing one of the mitigation is to have local manufacturing companies for these drugs, and that is their focus or vision. So by what time are they expecting to have that kind of initiative? Secondly, she has also said about counties providing, she is in touch with counties to be able to provide. What has been the actual response? Is the ministry getting positive feedback from counties in providing? If, Madam Speaker, the counties are unable even to give painkillers at our local dispensaries, how is it that they will be able now to do this? And if the response is negative, what is the ministry doing? And the last, the CHVs again, that they have been trained to be able to handle the epileptic patients. Honorable Speaker, we live around our constituencies, and we don't leave our constituencies. And most of the time, when we go to listen to what the CHVs are doing, epilepsy is one of the diseases that is always avoided and never spoken. Maybe can they do some further training and emphasis on the CHVs to be able to be giving this awareness on how you can handle an epileptic patient. Thank you, Honorable Speaker.
Thank you, Honorable Member for Nakuru Town East. And you've raised a very important issue, because I know I have seen the copy of the responses. I think it should be tabled so that the table office can make copies on request by members if they would like to indulge further. Honorable CS. And Honorable CS, kindly note the discomfort of members in accordance to Article 189 of cooperation between the national and county governments, so that you also respond to that issue on the many areas that you're doing collaboration on how effective the county governments will be.
Thank you, Madam Speaker and honorable members. On the issue of availability of the anti-epileptic drugs, and I would like to answer it together and globally in terms of availability of drugs, all drugs at health facilities. Madam Speaker and honorable members, we have had challenges in our supply chain. We have had challenges in our key institution, KEMSA, in terms of being able to meet all the essential drugs and supplies to avail them to the counties. Our fill rate has been very low. And the reason being that we have not received payments in time from counties when they do order for supplies. And equally, we have dead stock of COVID supplies that we are struggling with. So, Madam Speaker and honorable members, we have had a conversation with the Executive Office of the President, and we are in the process of recapitalizing KEMSA with 2 billion shillings. And this is to ensure that they buy the essential medical supplies so that then we can able to get 100% fill rate for all the essential supplies that are ordered for by the counties. Honorable Speaker and honorable members, on the issue of local manufacturing, the honorable member asked by what time. Honorable Speaker and members, we are already implementing this. In the ongoing tender at KEMSA, 50% of the tender was ring-fenced for local manufacturers. That is to ensure that we get good quality products at an affordable price so that we are able to increase our stock availability. Equally, Madam Speaker and honorable members, this month of October, we are launching UHC, and we will start from the 13th to the 20th. 2 of those days, we are having an expo of local manufacturers who shall be showcasing the products that are manufactured locally and that are available for use within the local facilities within the countries. On the question of the responsiveness of counties, Madam Speaker and honorable members, primary health care services is primarily a function of the counties, and we have a shared responsibility in ensuring that we direct the policy, we do the training, and we do capacity building. So far, the relationship through the Council of Governors has been cordial, and we are giving them training in terms of supply chain management for them to be able to order on time, timely ordering, to manage their stock levels so that they are able to be stocked up on whatever is required at the facility level. On the training of CHPs, Madam Speaker and honorable members, the training for CHPs is for them to refer patients to facilities, not to treat. Like epilepsy cannot be treated by a CHP. Theirs is to refer. But equally, we have trained them to provide education to families and communities so that we reduce the stigma that people that suffer from this condition receive within the communities. I submit, Madam Speaker and honorable members.
Thank you, Honorable CS. We will make progress to the next question by Honorable Sabina Chege. Honorable Kombe, maybe you are not there when we gave the direction, because we said it is one follow-up question by the questioner and one more from a member, which has already been done by Honorable Ikaria. Honorable Sabina.
Thank you, Madam Speaker. Madam Speaker, I rise to ask question number 157 of 2023 in today's order paper, as it was directed to the Cabinet Secretary for Health. 1, could the Cabinet Secretary outline the pharmaceutical composition of Velo, a nicotine drug packaged in pouches, including addictive nature and side effects of the said drug, as well as the regulatory mechanism that the Ministry has put in place to restrict access to or the sale of Velo drug to minors. Secondly, clarify whether the Velo drug has sneaked back to the market as rebrand of Lift, a similar drug that was banned in the year 2019-2020 by the Ministry of Health for not meeting Section 23, Part 1 and 2 of the Pharmacy and Poisons Act. And 3, explain whether the said drug is locally manufactured in Kenya, by who, and if not, provide details of the licensed distributors in the country, including whether the manufacturer or distribution in Kenya is legal. Thank you, Madam Speaker.
Honorable CS, as you respond to this one, there are also questions on what Velo is by honorable members, but make your response.
Honorable Speaker.
Wait, Honorable CS. Honorable
Madam Speaker, that question will come. For the sake of honorable members, I brought in samples of what Vero is, and I have them. I have not opened them, Madam Speaker, and they are easily
honorable member
in Kenya. So
Honorable Sabina,
members can cross over. They just see, but you cannot open because it is addictive. Thank you, Madam Speaker.
I want to confirm you've not opened or used it at all. All right, honorable members, let us hear the CS on this product. Those who would want to see it will see it from Honorable Sabina.
No.
Order members, now we are becoming disorderly. Kindly let the CS make the response. Honorable Sabina Shege, kindly withdraw the product from showing to the members so that you can hear the response from the CS. And I think you can do that later after the response. Honorable CS.
Honorable Speaker and honorable members, Velo is one of the tobacco products that tobacco industry has introduced into the market as countries tighten the regulations on tobacco smoking. The Tobacco Control Act of 2007 requires all manufacturers and importers of tobacco products to provide the content, ingredients, and emissions of their products. Velo, which is a brand name for B18 nicotine pouches, is a non-pharmaceutical substance, but a nicotine derivative substance composed of organic nicotine derived from tobacco leaf. Hence, Velo is a tobacco product as defined under the Tobacco Control Act of 2007 and as directed by the Ministry Correspondence of MOH 13-150, Volume 183, dated 21st January 2021. Honorable Speaker and honorable members, the chemical profile of the contents and constituents, ingredients, and emissions of Velo are many. I can quickly read through. Microstalline cellulose, which is a bulking agent. There's water in it. There's sodium chloride, which is a salt. There's xylitol, which is a sweetener. There's a flavor put into it. There's sodium alginate, which is a gelling agent. There's propylene glycol, which is a humectant. There's nicotine in it. There's sucralose, which is a sweetener also. And the sodium bicarbonate, an acidity regulator. The nicotine content of Velo can be as high as the nicotine content of other tobacco products, such as conventional cigarettes, traditional smokeless tobaccos, and heated tobacco products. Existing literature shows that for comparison purposes, conventional cigarettes typically contain an average of 12 micrograms to 19 micrograms of nicotine of tobacco, while heated tobacco products typically contain an average of 14 to 18 micrograms of nicotine. Users can potentially consume up to 90% of nicotine given that they are taken orally. These new product variants contain different flavors and additives which suppress the strong smell of tobacco and also makes them attractive and acceptable to the users. These flavors are berry, strawberry, menthol, mint, peppermint, lime, spearmint. Some of these novel tobacco products besides nicotine may contain other analytes such as heavy metals, and this may cause toxic to the body. Honorable Speaker and honorable members, the regulatory mechanisms to restrict access to Velo, nicotine and its salts are classified as Part 1 poisons under the Poisons List Confirmation Order under Cap 244 of the Pharmacy and Poisons Board, which regulates nicotine and its salts. This informed the initial basis for regulation of nicotine pouches by the brand name Lift. However, Cap 244 excludes nicotine that occurs naturally in tobacco. Therefore, the Cabinet Secretary of Health of then, on the 21st of 2021, directed that nicotine pouches, including Lift, be regulated as a tobacco product under the Tobacco Control Act of 2007 and required that they meet the requirements for tobacco products. Leaf is no longer in the market, but nicotine pouches by the brand name Velo, manufactured by the same manufacturer, BAT, is regulated as a tobacco product under the Tobacco Control Act. The ministry, in collaboration with other ministries and state agencies, are in the process of reviewing the legislative and regulatory frameworks to address the new and emerging tobacco products. This will include the development of legislative and administrative instruments for the regulation of tobacco products' content and emissions, testing and disclosure of content to government authorities and the public. Restrictions of access to and by minors. The sale of tobacco products to and minors is prohibited by the Act, and all sellers of tobacco products are required to verify the age of a young purchaser. Further, the Tobacco Control Act prohibits the manufacturer seller of objects that resemble tobacco products, which would reasonably appeal to persons under the age of 18 years. The sale of tobacco products via automated vending machines is also prohibited by law to prevent access to these products by minors. Offering tobacco products for free or by sales promotion is also prohibited. The Tobacco Control Act prohibits all direct and indirect forms of advertising and promotion of tobacco, tobacco products, or tobacco-related brand elements, including sponsorship associated with young people by the tobacco industry. Further, it prohibits false promotion by means of packaging that are misleading or deceptive, or that are likely to create an erroneous impression about the characteristics, the health effects, health hazard, or social effects of the tobacco products or its emission. In addition, it is prohibited to advertise or promote tobacco products by means of testimonial, for example, role models or persons that can influence young people, or an endorsement in any manner, including that which is misleading. It also prohibits advertisement by means of organizing or promoting or sponsoring of sporting, cultural, artistic, or recreational trade fairs and exhibitions, shows, education or entertainment programs, event or activity. Display of tobacco brand elements on non-tobacco products is prohibited, including on clothing. The government, through the Ministry of Education in collaboration with the Ministry of Health, has integrated information on the dangers of tobacco and tobacco products in education curriculum. This is intended to inform the children on the effects of tobacco and is aimed at discouraging initiation or motivate quitting tobacco use, and to create change agents in the society for tobacco control, including at peer and household level. Speaker and honorable members, the second part of the question, whether Velo drug has been sneaked back to the market as a rebrand of Lift, which is a similar that was banned in 2020 by the Ministry of Health due to it not being able to meet Part 1 and Part 2 of the Pharmacy and Poisons Act. Velo, Honorable Speaker and members, I want to confirm Velo is a rebrand of BAT's Lift, which was recalled off the Kenyan market by BAT following a directive by the immediate former Cabinet Secretary. Velo hit the Kenyan market in June 2022 following a moratorium that was issued on the 15th of June 2022 by my immediate predecessor. Notably, the said Lift was not banned, but its registration and regulation were changed from Pharmacy and Poisons Act Cap 244 to regulation under the Tobacco Control Act of 2007. On the third question, Honorable Speaker and honorable members, explain whether the drug is locally manufactured in Kenya and by whom, and if not, provide details of the licensed distributors in the country. Honorable Speaker and honorable members, Velo is imported from Hungary but distributed in Kenya by BAT Kenya Limited. British American Tobacco, that is BAT Kenya, is licensed as a tobacco product manufacturer in Kenya and have sought manufacture nicotine pouches in Kenya, but this has not yet started. No local manufacturer of nicotine pouches exists in this country. Therefore, all nicotine pouches are imported. Honorable Speaker and members, I submit.
Thank you, Honorable CS. Honorable Sabina.
Thank you very much, Madam Speaker, and I want to thank the CS for confirming that what was banned in Kenya is Lift, is what has come through as Velo. Madam Speaker, what had advised then, I would want even the CS to clarify the moratorium that was given by for the predecessor to Lift. That was June 2022, to allow Velo back into the market. And again, having been not manufactured in Kenya, coming from Hungary, why would we as a country allow an addictive, a drug? That means when it says it's addictive, and it's actually very clear, why should we allow a drug to come into this country? Madam Speaker, I am a mother. Madam Speaker, I can tell you, we only have a very slight, if you were to look at this, warning at the back, over 18 only. Even as per the Tobacco Act, Madam Speaker, it says for the side effect, you should write in both English and Swahili, half at the back. If you look at this Vero, it is just slightly, might be a quarter at the back. It also says 30% at the front, and you can see, Madam Speaker, it's very tiny. And the only effect they have said, this product contains nicotine and is addictive. But Madam Speaker, CS having come from the health, she knows that nicotine affects human body in other areas. For instance, the issue of cardiovascular diseases, the issues about affecting the reproductive health, and many other side effects that nicotine has, Madam Speaker. And my question is, why should the ministry allow this drug to be sold in the market? Why did we allow the British tobacco, they are not even producing it here, to import a drug to come into the Kenyan market? Madam Speaker, this government, and especially even our areas, we are talking about fighting addiction. That's why we even have Nakada. This is a drug that is clearly, even if they are saying it's nicotine, written that is addictive. And Madam Speaker, I just walked out here and I sent my driver to go and look for it. It is readily available anywhere. Our school-going children, when they are going back to school, they are buying Velo.
You've made your point.
So, Madam Speaker, I would ask the CS humbly that they reconsider the decision, and this should be banned until it is investigated properly, Madam Speaker, so that we save our generation and we save our young people. I submit, Madam Speaker.
Thank you. Honorable Mayaka.
Thank you, Honorable Speaker. And Honorable Speaker, I just want to also emphasize and ask the CS, because right now, if you actually compare the kind of Velo sold in Kenya to the ones sold in countries like Australia, Kenya has the one that has even a higher level of addiction than other countries. You walk to a petrol station, you can buy it. You go to a chemist, you can buy it. Yep. And they actually don't even ask for an ID when somebody buys Velo. And so I just want to support and emphasize and ask Madam CS to reconsider and have a total ban on Velo. Because I can tell you for a fact, out of experience and experimenting, just to understand what Velo does. For 5 minutes, it takes you to heaven and then quickly brings you back down to earth. So it is not a good product, for sure. And we need to
Honorable Mayaka, I do not want to ask how you know that, but I will say, Honorable CS, there is a lot of interest in this matter, and I think the one issue that you should really address is why the reintroduction of an already withdrawn product, despite having another name, hits the same market, because there was a reason why it had been withdrawn. So I will indulge the Chair of Health Committee for 2 minutes, maximum.
Chair, thank you. Honorable Speaker, thank you. And CS, thank you for the responses. But in your response, you refer to the Tobacco Control Act of 2007. And you know, when you look at the Tobacco Control Act of 2007, it talks of tobacco at that time, where we had maybe smoking, but even the smoking now has even gone through, there are various forms. You have electrical cigarettes, and now we also have these pouches. My question, because even as members raise, you know the onus is on this House to make amendments to the Tobacco Control Act. I want to know this from the CS. And you see, like now, even in the tobacco control, even the tobacco fund is supposed to put some tax measures to include even felon and others that are considered to be nicotine or tobacco-like substances.
Thank you, Chair.
When do you intend to bring to the House the amendment to the Tobacco Control Act 2007?
Thank you, Chair. And even as you respond, yes, I think, Honorable Chair, you have alluded to it. The lawmaking house is not outside this House. It is in this House. So I also hope that we take our responsibility. Honorable Member for Thika, I will indulge you for a minute. Follow-up question, not debate.
Thank you. Thank you, Madam Speaker. Madam Speaker, mine was to add and ask the CS. Some of these things that we are discussing at the floor of the House, and we know they are harmful. We should even be dealing, whether it is coming through the BAT or whatever channel that is coming in, we invite them or they go to the ministry, to the Committee on Health, so that we can know what we are dealing with, and we don't even be wasting a lot of time. Some of these things, we need even to discipline BAT, because at the end of the day, the people, it is harming our children. Because if you look at the way that drug is packaged, it is to hoodwink the young ones. It is nothing to do with the
Thank you, Honorable
adults.
Member. For Thika, I will need to have a copy of that so that you make reference, I can refer. Member for Navaholo, please close that section for questions. We'll have the CS respond.
Thank you, Honorable Speaker. Honorable Speaker, I wish to thank the CS for Health for her submissions. But my question is, one, does the Ministry of Health work hand in hand with other departments, especially Kenya Bureau of Standards? When you look at this package, Honorable Speaker, it is stamped Kenya Bureau of Standards. And when you look at the narration by the CS, it automatically puts off that this kind of a substance is not even supposed to be in the country. Do they work hand in hand, Honorable Speaker? Number two of it, Honorable Speaker, I just want to find out if it might be in order that, Honorable Speaker, you order that this substance be removed from the shelf. The reason being, Madam Speaker, the young, especially as parents who have girls, look at it can be applied in two scenarios, Honorable Speaker. Maybe it's used to sniff. It is used even to be abused in terms of how it's used, Madam Speaker. In other parts, Honorable Speaker, it can be inserted. Madam Speaker, it's important you order that this substance be removed from the shelf of the Kenyan supermarkets. Thank you, Honorable Speaker.
Honorable members, I want to close this. Member for Rueda, Honorable Obo, what is out of order?
Speaker alikuwa anasema waziri atueleze wale wakiendelea kuuza vero, sisi kule Lamu tungangana kutafuta dawa ya kuondoa ile hamu ya matumizi ya madawa ya kulevya, na inakuwa mpangilio mrefu. Nimeomba kutoka bunge la 12 mpaka sasa, barua zote nimefanya tuletewe methadone na hatujaletewa, na huku tunaendelea kuuza vero na sisi kule tunamalizika na cocaine. Tunatafuta ministry tuletee hiyo methadone pale Lamu East. Kwa hivyo mna mipangilio gani ya kutuletea hiyo methadone ambayo nimeomba kwa muda mrefu mpaka leo haijaletwa Lamu East Father Hospital?
Honorable CS, please make the responses.
Thank you, Madam Speaker and honorable members. If Madam Speaker was to make a declaration that velo be removed from the market as a Minister of Health, we'll be the happiest, because we'll have saved the lives of many Kenyans. But as it is, Madam Speaker and honorable members, we are all relying on the Tobacco Control Act of 2017 and of 2007. So we have put together a technical team that is working at it to review the 2007 Act. Then we shall be bringing it to our health committee so that they can bring it to the House. Madam Speaker and honorable members, in regards to methadone, it is a big value chain, and I would seek your indulgence, honorable Speaker and honorable member, that I do as a specific response to that question and share it with the honorable member. I submit.
Thank you, Honorable CS and honorable members. However powerful the speaker may be, I cannot speak for you. So there exist available avenues of doing this through a motion to be a declaration or a resolution of the House, and I would urge you members to actually pick it up. Next question by honorable member for, wait a minute, the honorable member for Kaiti, Honorable Joshua Kiluki. Is he in the House? No, has he written to the Speaker on a deferment? Question is by the nominated member, Honorable Irene Mayaka.
Thank you, Honorable Speaker. Honorable Speaker, I would like to ask the Cabinet Secretary, number 1, to clarify whether the government has conducted a national health survey to better define the burden of mental health illness in the country and to provide details of the funds available or allocated for the implementation of promotional, preventive, and curative measures to alleviate the burden of mental illness, and clarify whether there is an interagency approach to deal with mental health in the country. Number 2, could the Cabinet Secretary state the measures the ministry has put in place to establish a mental health and happiness commission, including the creation of annual National Happiness Index to be included in the presidential annual report, as well as whether the state has any plans to provide psychosocial services in learning institutions and to capacity build teachers to identify and assist impacted students. And number 3, could the Cabinet Secretary clarify whether psychological services are provided in the various security services institutions, whether regular mental health support sessions for personnel are held in the workplace, and further disclose institutions, if any, that serve persons who have conquered mental illness in order to follow their development and ensure they do not relapse.
Honorable Kombe,
Thank
you
you.
can only ask a follow-up question after the response. Hold on.
Thank you, Honorable Speaker and honorable members. According to the Kenya Mental Health Policy 2015-2030, the national government estimates the burden of mental illness at 25% among outpatients and 40% among inpatients in different health facilities, with an estimated prevalence of psychosis stated as 1% of the general population. Despite substantial research being undertaken in Kenya to examine the burden of mental illness, the majority of these are region or population specific and thus may not be generalized to the entire country. The Task Force on Mental Health recommended that the government conduct a national mental health survey to better define the burden of illness in the country. The progress that we have done so far, plans are underway to conduct the first national baseline mental health survey. The ministry has appointed a technical working group, which was done in March 2022, to spearhead this survey. This technical working group is composed of officials of the Ministry of Health, the Kenya Medical Research Institute, academia, county governments, development partners, and the Kenya National Bureau of Statistics, among others. The technical working group developed the study proposal and got ethical approval to conduct the National Baseline Mental Health Survey. The technical working group engaged the World Mental Health Survey Consortium for capacity building on research assistance using the appropriate study composite international diagnostic interview tool for assessing mental disorders at the community level. This survey has been included in the Division of Mental Health's annual work plan for financial year 2023-2024. Currently, the ministry is working on mobilizing resources to commence the survey. The Ministry of Health has included mental health burden indicators in the sector surveys, particularly the Kenya Adolescent Health Survey of 2019, which examined the symptoms of mental health, alcohol and substance use, and the risk factors, including adverse childhood experience among adolescents. The Ministry of Health is currently piloting the inclusion of disease-specific mental health indicators, the Kenya Health Information System, in 14 counties to better understand the burden of mental illness at health facility level. On part 2, on implementation of promotional, preventive, and curative measures to alleviate the burden of mental illness. Madam Speaker and honorable members, the ministry has made significant efforts towards strengthening the country's mental health system. The ministry has developed national mental health policy documents, including the Kenya Mental Health Policy of 2015-2030, the Kenya Mental Health Action Plan 2021-2025, National Suicide Prevention Strategy 2021-2026, Kenya Mental Health Investment Case 2021, and Mental Health Training Manual for Community Health Promoters 2021. Furthermore, the ministry has finalized the first national mental health standards and clinical guidelines for use in building the capacity of primary health care workers to identify and manage people living with mental illnesses. Additionally, the ministry has provided technical support to counties in the implementation of national policy documents. In this regard, the ministry has supported counties in developing county-specific costed mental health action plans to drive the agenda of mental health at the county level. At present, 4 counties have developed and are implementing county-specific mental health action plans. These counties are Nyeri, Kilifi, Kajiado, and Murang'a. The counties are at different levels of implementation of measures to alleviate the burden of mental illness, with Nyeri County making significant strides in mainstreaming mental health through its inclusion in the County Integrated Development Plan. In July 2023, the ministry held a consultative meeting with various stakeholders on children and adolescent mental health. This meeting highlighted the fragmentation of school mental health interventions within the government by various stakeholders. To address this, the Ministry of Health plans to establish a national school mental health technical working group to improve the collaboration and coordination of school mental health interventions, including development of guidelines on school mental health. The second part, the measure the ministry has put in place to establish a mental health and happiness commission, including creation of annual national happiness index to be included in the presidential annual report, as well as other states has any plans to provide psychosocial services in learning institutions and to capacity build teachers to identify and assist impacted students. Honorable Speaker and honorable members, the Task Force on Mental Health 2019 identified the absence of a unified mental health leadership and governance structure in the country and made a recommendation for the establishment of a National Mental Health and Happiness Commission, which will be the overall mental health authority in the country. This commission will be tasked with monitoring the state of mental health and happiness among Kenyans using an annual happiness index to help guide public policies. At present, this commission is not in place. However, progress has been made towards strengthening the mental health leadership and governance structures in the country. This has been undertaken through the following: creation of the Office of the Presidential Advisor on Mental Health. This was done in 2021, tasked with the implementation of recommendations by the Task Force on Mental Health. However, the term of the first Presidential Advisor on Mental Health ended. So far, the office is vacant and names have been submitted for possible consideration. 2, the Kenya Mental Health Amendment Act 2022 provided the legal framework for the establishment of mental health leadership and governance structures at national and county level. At the national level, this led to the appointment of the Kenya Board of Mental Health through a Gazette notice of 8818, that was in July 2022, and Gazette Notice 9284 of 5th August 2022. The Kenya Board of Mental Health serves as the oversight authority for mental health and has an important responsibility towards improving the mental health of the population and safeguarding the rights of persons with a mental illness. Madam Speaker and honorable members, at this point I would like to respond to a question that had been raised earlier regarding the operationalization of the Mental Health Board. We have made strides in the operationalization, and so far we are waiting to inaugurate the board upon our supplementary budget being approved that has put in place the funds that will be used by this board. At the county level, Madam Speaker and honorable members, the Act gives provision for appointment of county mental health councils mandated to spearhead all matters relating to the status of mental health and mental illness in the county. However, the counties are yet to appoint their county mental health councils. Therefore, the ministry is currently planning on disseminating the Kenya Mental Health Amendment Act 2022 to the county executive committee members for health who are mandated by law to appoint the councils through the Council of Governors. Part 3 on provision of psychosocial services in learning institutions. Honorable Speaker and members, globally it is estimated that 50% of mental health conditions develop by the age of 15, and 75% of mental health conditions have developed by the age of 25 years. Furthermore, the Task Force on Mental Health identified children and adolescents as a special population in mental health who require targeted intervention. In this regard, the following recommendations were made. Youth counselors should be employed in primary schools to provide counseling services. School nurses should be required to undertake training on youth and adolescent health in order to better meet the needs of adolescents. Build capacity for teachers to identify and help the affected children in schools. In implementations of this recommendation, the ministry has made the following progress. In 2022, the ministry, in collaboration with Office of the Presidential Advisor on Mental Health, was able to support an initial multi-sectoral workshop towards development and implementation of mental health literacy curriculum for teachers. The Ministry of Education is represented also in the National Mental Health Stakeholders Forum and National Multi-Sectoral Suicide Prevention Committee to enable collaboration on safeguarding the mental health of students in learning institutions. In July 2023, the ministry held a consultative meeting with stakeholders on children and adolescents' mental health. This meeting highlighted the fragmentation of schools' mental interventions within the government's stakeholders. To address this, we have established a National School Mental Health Technical Working Group to improve the collaboration and coordination of school mental health interventions, including the development of national guidelines on school and mental health. The third bit of the question, to clarify whether psychosocial services are provided in various security service institutions, whether regular mental health support sessions for personnel are held in the workplace, and further disclose institutions, if any, that serve persons who have conquered mental illnesses in order to follow their development and ensure they do not relapse. Madam Speaker and honorable members, the Task Force on Mental Health identified security personnel as a special population who require consideration and attention, as their needs may not be fully addressed by primary health services. In this regard, the task force has made the following recommendation. Different security service institutions must provide psychosocial services for both managers and staff of disciplined institutions. The institutions should establish regular staff support sessions on mental health in workplace for the officers. The ministry should continue mainstreaming mental health in all sectors, including the disciplined forces. On implementation of this recommendation, we have made the following progress. The National Workplace Mental Wellness Guidelines were developed with input from the National Police Service. These guidelines have been finalized and due for launch this October. The implementation of these guidelines by the security apparatus is key to the promotion of mental wellness, prevention of mental illness, and support for officers with mental problems. Madam Speaker and honorable members, in the Shakahola incidents, the Ministry of Health nominated 7 psychologists and 2 psychiatrists to support the Directorate of Criminal Investigation in provision of mental health and psychosocial support services to those affected, including security officers. The National Police Service is represented in the National Mental Health Stakeholders Forum and National Multi-Sectoral Suicide Prevention Committee to enhance collaboration on mental health matters. I submit, Madam Chair and honorable members.
Thank you, Honorable Mayaka.
Thank you, Honorable Speaker, and I'd just like to thank the CS for her very comprehensive responses. I, however, have a follow-up question, especially on the recommendation that you shared in terms of having youth counselors in schools. And the reason why I'm asking this, Madam CS, is because we've had so many cases of suicide in schools. Where I come from in Nyamira and Kisii, on a daily basis on the radio, you hear cases of children who have committed suicide. So what I want to ask is, for example, we do have PE as being part of the timetable in schools. Why can't we have guidance and counseling also being part of the timetable so that it doesn't become optional? Because in most cases, it's very hard for you to find someone volunteering to go and see a guidance and counselor because they feel they have a problem. Most instances, someone who has mental health issues, they don't even know that they're suffering from it. Case in point, Madam CS, is like yesterday when we had the issue about irregi girls and the mysterious disease that, as at today, has affected 95 students. So my question is, for the rest of the students who are not affected in school, who is ensuring that a guidance and counselor is speaking to them so that that does not then affect them mentally? So 2 issues there. One, on why can't we make mental health and guidance and counseling become part and parcel of the timetable in schools? And secondly, proactive measures when schools get affected by issues like what happened in irregi girls. Thank you.
Those are enough. Honorable Kombe.
Thank you, Honorable Speaker. Madam Speaker, mental disorder and epilepsy can be easily cured, but I'm not sure as to whether the CS is aware that reflexology can be used to cure mental disorder and epilepsy. Alongside that, Madam Speaker, suicide can also be prevented by the use of reflexology when it's applied to the adrenal gland. Madam Speaker, last.
Ask the question.
If I have already asked the question, but now I want to add, are there any plans for reflexology to be taught in our KMTCs alongside physiotherapy? Thank you.
Honorable members, let us not answer for the ministry. We ask follow-up questions. Honorable CS, please respond.
Honorable Speaker and honorable members, the youth counselors in schools was out of a working collaboration between my ministry and the Ministry of Education. The curriculum development is a function of Ministry of Education. So we shall be working together with them to see how we integrate the guiding and counseling, specifically to work on mental health, to see how it can be put into the curriculum. However, as a function, it lies with the Ministry of Education. But through a one government approach, we shall approach the ministry so that we work together. On the issue of counseling, specifically for the case that you have mentioned of Eregi, yesterday evening we dispatched officers from the Ministry of Health who are in the school, and one of their primary responsibilities was to ensure that there's proper counseling of not just the students, but the teachers and the community around Eregi as we wait for the final results from KEMRI. Honorable Speaker and members, at the Ministry of Health, we have a division of traditional and alternative medicine. And this division works together with those who provide traditional and alternative medicine and alternative ways of healing to be regulated in some form. So I would be asking my Director General, who is here with me, so that then we beef up and understand the issue of reflexology and how it can be incorporated in training at the Kenya Medical Training College. I submit, Madam Speaker.
All right, thank you, CS. We'll go to the next question by the member for Kabete, Honorable James Wamashukuru. We already gave guidance on the number of questions. I have even indulged you members, so I will not. Member for Tetu, you are actually on your phone when the CS responded to your issue directly. So kindly, Honorable Wamashukuru, take the floor.
Thank you, Madam Speaker. This is question number 307, year 2023. Could the Cabinet Secretary explain why the National Health Insurance Fund does not provide a medical insurance health cover to facilitate intersex person undergoing gender transformation?
Honorable CS.
Honorable Speaker and honorable members.
And while at it, Honorable CS, please educate these members on what an intersex person is, because I can already hear the member for Nyando shouting LGBTQ. Kindly educate the House on who an intersex person is.
Thank you, Honorable Speaker and honorable members. The National Hospital Insurance Fund procures benefits for its members irrespective of their status, gender, sex, race, age, marital status, and pregnancy. As per the provision of the Bill of Rights, in this regard, a medical insurance cover and the scope of benefits therein are available to all members as guided by the policy provisions on the strategic procurement of medical benefits. The current scope of procedures covered under the surgical benefit package includes surgeries related to intersex persons. The healthcare provider is required to give clinical justification of the procedure to be undertaken. The request is taken through a pre-authorization process to verify the clinical indication. This scope of cover has been contracted since July 2022. Honorable Speaker and honorable members, we have a specialty which is pediatric surgery, procedures for urethroplasty, for hypospadiasis and epispadiasis. It is a complexity measure, and currently the NHIF is doing reimbursements of 120,000 for those surgeries. Other procedures related to intersex persons that are covered are urological surgery, orchidectomy and excision of the spermatic cord, urological surgery, orchidopexy bilateral, and urological surgery, combined abdominal and vaginal operations on the bladder. The other intersex medical interventions, like hormone treatment, are not comprehensively covered for the national
Honorable
scheme.
CS, Honorable Member for Busia. Is it the English that is too tough? What is out of order?
I want Wanjiku to understand. The CS is not communicating.
What is your point of order, Honorable Catherine?
I'm just hearing Ochipo, there's something. And in the dictionary, it's not there.
Honorable CS.
If
Honorable
she can't
CS,
explain.
we have heard you, Honorable Manyo.
She's
Honorable
struggling to even pronounce herself. So that means even it's not clear to herself.
Honorable
so can she
CS,
break down?
Honorable CS, I know these are medical terms. Please do continue with your answer. If any member will need clarification, I'm sure there are doctors in the house, led by the one member for Endebess, to clarify.
Thank you, Chair and honorable members. Those are medical terms that a tongue may not easily be able to pronounce them. I'm struggling with them indeed. But in short, one of them is excision of the spermatic cord, and the other one is combined abdominal and vaginal operations on the bladder. Madam Speaker and honorable members, intersex persons are persons who neither male nor female. Madam Speaker and honorable members.
Honorable members, I can hear you shouting very derogatory terms to the CS, and you're distracting a member for Buri. And by the way, just for your information, in the last census, we actually had a column for intersex persons in this country, and there were registered 1,400 and something. So I think let us give the CS the moment to finish, and then we'll ask a few follow-up questions.
Thank you, Madam Speaker and honorable members. The other intersex medical interventions we have, like hormone treatment, are not comprehensively covered under the national scheme. The fund will be conducting a benefits review process this October 2023 to see if there's a possibility of inclusion of this. We request your input on enhancing the scope of cover for intersex persons based on the 12-point prioritization criteria and the health technologies assessment evaluation. However, honorable Speaker and members, I need to mention that we have developed an essential benefits package. This essential benefits package does not discriminate against anyone. It has no limitations, it has no exclusions. I therefore seek the support of this House in assisting us with the reforms at NHIF. I submit, Madam Speaker.
Thank you, Honorable CS. Honorable Amashkuru, do you have a follow-up question? If not, do you
I'm
have
satisfied,
a follow-up?
Madam
If
Speaker.
not, I will give your chance to the member for Endebess to give a point of information. Very quick.
Madam Speaker, when we talk of intersex person, this is people who, this is a congenital, would say congenital malformation, somebody who is born with abnormality within the genitalia, where you cannot determine whether it's a male or a female. And this happens. And when we say hypospadias or epispadias, it is depending on the position of the urethra. And those operations, this for Monya, who is not paying attention. And when we say we're doing those operations in terms of occultopexy, in Tanzania they say teramusha kende, operation teramusha kende. You're bringing it down because it's up there. So these are from the socket downwards. So I think you get it now there.
We get it, Honorable Member for Honorable Member for Endebess. And I think that was for Honorable Manyo. I hope you can get the answer if you didn't hear everything, so that you can refer to for your explanation. Follow-up question by Honorable Umi.
Thank you, Madam Speaker. In the same breath of NHIF cover for vulnerable people, I also wanted to ask the Cabinet Secretary what the benefits for persons with invisible disability like autism, dyslexia, and ADHD, because the cost of therapy is very high. Thank you.
Thank you. That is very quick and precise. Member for Funyula.
I also just wanted to follow up on the same issue, whether NHIF cover also covers matters related to treatment for inability to bear children, both male and women.
Honorable Gekaria, I want you to be the last one. Honorable CS, I hope you have the issue by Honorable Funyula, whether infertility is covered. Honorable Gekaria, 1 minute.
Actually, it will be even less. Honorable Speaker, thank you. It's just to ask, in law, we have alternative dispute resolution, where you can get other means. Is you talking out to that person not to have an operation and just remain the way they were born an alternative? Thank you, Honorable Speaker.
CS, kindly respond.
Thank you, Madam Speaker and honorable members. In terms of benefits at the NHIF for persons with invisible disabilities, which the honorable member has cited autism and others, we have a guideline at the ministry, and all the benefits at National Hospital Insurance Fund are within the guidelines that we have provided. So long as this has been clinically proven, then they are covered under NHIF. But however, we have people who request for others like stem cells, which we consider cosmetology, and then they are not covered under National Hospital Insurance Fund. Thank you. Regarding the alternative dispute resolution, I believe that would be an individual responsibility, and once a person appears at the facility seeking guidance, we have experienced and trained the officers to be able to handle such. I submit, Madam Speaker.
Thank you. We'll go to the next question by the member for Subukia. We have a letter for deferment, so we will defer that to the next time that the CS appears, if he has not come in the House. We'll go to the next question by the member for Mumias East, Honorable Peter Salasia.
Thank you. I wish to ask the following. Could the Cabinet Secretary explain the steps taken by the Kenya Medical Training College, KMTC, to secure the uninterrupted availability of lecturers in each of its campuses? Thank you, Speaker.
CS.
Thank you, Honorable Speaker and honorable members. The Kenya Medical Training College has put in place measures to ensure that there is uninterrupted learning in all the campuses in the country. And thank you to this Honorable House that in the budget estimates for financial year 2023-2024, the college was allocated 804 million to address the staffing shortage. Following this allocation, the college has begun the recruitment process. Currently, the college contracts part-time lecturers to bridge the shortfall. And this, we are clear that we should be able to bridge it after we have finished with the current recruitment that is ongoing. But before even this is finalized, we also work and collaborate with county governments who second staff to the colleges in many discipline areas to support learning of students. Moreover, the college has an e-learning platform where lecturers across campuses share teaching and learning materials. However, the college requires additional 483 lecturers for the new 13 completed campuses and 8 satellite at a cost of 985 million, and that we shall be bringing in our supplementary budget. I submit, Speaker and honorable members.
Honorable Salasia, do you have a follow-up question?
Yes. Speaker, I want to thank the CS for the good response that she has given to us. But there's one concern that maybe I would wish her to address, and because as members of parliament, we have put a lot of resources in the Kenya Medical KMTCs across, even like in my place. I've invested a lot, and I want to see the break even. And you realize that if I can have only like 400 students, it's not enough for me, because if it's the classes I have, if it's what I have. So can CS maybe assure us that we are going to have the students, because we know that the health, as it's very marketable courses, which should be given the priority. So CS, maybe you can explain to us that you are going to give us more students. Me, I need 2,000. Will you give me 2,000, Madam CS? Thank you.
We'll have one more follow-up question by Honorable Sunkuli. And honorable members, you know we have business to transact up to 9 p.m. So I will give Honorable Sunkuli, then I'll give the CS to respond.
Madam Speaker, I just want to ask the CS to confirm that, in fact, the MTCs have been overdeveloped. That, in fact, that the development of medical training colleges is not matched by availability of people, trainers to train the students, and whether the ministry will consider in future concentrating on quality rather than quantity, because most of these so-called newly built MTCs are actually structures with no content.
Yes.
Thank you, Honorable Speaker and honorable members. The issue of availability of students to the existing MTCs. Honorable Speaker and honorable members, I would like to seek the indulgence of members that we look at this as a production and development value chain of health professionals in the country. Chair, honorable members, the courses that are being taught at Kenya Medical Training College are technical courses. And for us to be able to have competently trained, quality trained health professionals, we need to have a patient to trainee ratio that is optimum. These students need hospitals where they can go and do their practicum. And we do not want to have half-baked trainees. Therefore, it's a delicate balance. We do not pray that Kenyans are sick so that they get to hospital so that we achieve the patient to trainee ratio. But we shall work within the existing facilities. And Chair and honorable members, I would like to seek the indulgence of the members that you allow us to equip and operationalize the existing colleges without